Hi, I'm Dr. Shimmel Shah, and I'm the director of the Transplant Program here at UC Medical Center. And we're going to spend the next 30 minutes talking about liver transplantation at the University of Cincinnati, what you need to know, what we need to tell you, what we need to educate you on, and how the process works. This is our team, many members of the team which you will get to know over time. What about us? So our goal is to provide the best care that we can in the region. We're using cutting-edge technology and research programs with the goal to improve patient care. We have volume that's competitive with the largest liver transplant programs in the country. Last year, out of 130 liver transplant programs, we were 18th in overall volume. We're always training the next generation of providers, whether it's surgeons, medical doctors, nurses, dietitians. You'll meet them along the way. That's part of our mission. But overall, our aim is to get you transplanted. How do we do this? Well, everything in liver transplantation is based on the MELD score. The MELD score is a mathematical calculation of 4 lab tests. The sodium and the creatinine, which are a measure of your kidney function, the bilirubin and the INR, which are a measure of your liver function. It's a complex formula, and you can find it on any website, but if you plug in your labs, it spits out a number. The MELD score predicts your risk of dying without a liver transplant. So essentially, the liver transplants are given out with the sickest first algorithm. And so the MELD score tells us who's sickest first, with the highest MELD score being the sickest person, and then working its way down. The liver transplant is a risky operation, so we should only do it if you need it. The risk of dying from a liver transplant from the operation itself and in the first 30 days is about 3%. So we should only do this operation if you're going to benefit from the operation and tolerate the risk. In this example, the MELD score is 30. When a liver becomes available, the way the livers are given out is purely based on the MELD score. It doesn't matter how old you are, where you live, how long you've been on the list. The only thing that matters is this mathematical calculation of your lab tests. And let's see how that works. So a MELD score of 30, if it's drawn out with MELD score on the x-axis and 3-month survival on the y-axis, tells me that you have a 3-month survival of only 60%, or conversely, a 3-month risk of death of 40%. So really high. This person really needs a transplant. When you have the highest score, which is 40, you can see that your survival is only about 5% over the next 3 months. Another way to look at it is a survival benefit based on your MELD score. So the MELD score is on the x-axis, your life expectancy is on the y-axis. The white line is people that get transplants. The black line is people that stay on the list. And as you can see, as your MELD score gets higher, your benefit from a transplant obviously increases. And we've marked out 29 because that's where many people feel the curve really changes. But the other way to look at it is you will benefit from a transplant with a MELD score of 9 or higher. It just is a lot better of a benefit as you get higher and higher. Now the MELD score is not perfect, but it's the only thing that we're using right now in terms of allocation. What are some other things that we're doing here at UC? We're trying to streamline the workup process to eliminate unnecessary tests and get people listed faster. We've developed a comprehensive clinic. It's usually on Monday afternoons to reduce the time for the workup, along with education Monday mornings. We've developed a transplant clinic up in Westchester because we have so many patients from the Dayton area. The surgery always occurs here, but we can do a lot of our clinic visits up at Westchester. And then we have novel treatments for liver cancer and bile cancer to get more people transplanted. Here's a map of where people live over the last couple of years have been transplanted. And as you can see, we dominate the volume in Cincinnati and Dayton, but also extend up to northern Ohio and all throughout Kentucky. Here's some figures about our transplant activity that you can find on the UNOS website. This is our waiting list activity summary over the last couple of years. And the important number to know about the waiting list is our death rate. And our death rate on the last report was 6.4%. The national rate was 8.3%. So we're doing okay in terms of waiting list activity. What about 1 month survival? So our survival has always been pretty good. This is our 1 month survival. We're at 97.4% and the country's at 97.5%. So doing okay with 1 month survival. 1 year survival is around 92, 93%. And what about longer term? Here's 3 year survival. We're at 84% and the country's at 85%. So doing okay there. Here is a graph of our volume over the last few years. As I mentioned, we're one of the busiest programs in the country. In 2018, we did 115 transplants. In 2019, we did 133. And our volume so far this year is on pace with previous years. What's our immediate goal when you come in for your visit? Our goal is to get evaluated for the transplant list. You're not here to get a transplant because we can't transplant you unless you're on the list. So we look at this as a two-phase phenomenon. First is to get on the list, and then to figure out how to get transplanted. And just because you're listed doesn't mean you're going to get a transplant, because many people have low MELD scores where they qualify to be on the list, but they don't necessarily need a transplant just yet. And I look at that as like an insurance policy, because many people live at MELD scores of 10 or 11, and they get really sick and have a MELD score of 30. This way we already know everything about you and we're ready to go. The goal of your visit is also to understand expectations and commitments required, not only for you, but for your caregiver. Here's a picture of a cirrhotic liver, nodular, hard, lumpy, bumpy. There's the gallbladder. Here's a picture of the liver outside of the body. So let's say that you're put on the waiting list and you really need a transplant. How do we get you transplanted? Well, there's many types of donors, and I'm going to review these a little bit here. Brain dead donors is a lot of what we do here at UC. It's about 88% of our volume. And we really categorize the brain dead donors into 3 different types. A standard criteria donor is not necessarily a medical term used anymore, but essentially is a perfect organ of someone that dies unexpectedly. 20, 30, 40-year-old or so, a type of donor. An extended criteria donor is someone who is not as good as a standard criteria donor. Maybe they're older, maybe they're obese, maybe the donor is in shock, and they run into problems where the liver's still usable, but it's not as perfect as a standard criteria donor. Sometimes it is, but it may not be. And very common in our area here are the increased risk donors. These are donors that have increased social risk, things like IV drug use, unclear social history, being in jail, but the IV drug use is very common in Southwest Ohio, and we see a lot of that. Donation after cardiac death donors are about 10% of what we do. This is where the donor is not brain dead, but the family still wants to donate. So we pull the breathing tube, and if they die within a certain amount of time, we quickly go to the operating room and take the organs out. Split liver donors is where there's a perfect liver, but there's a sick child that has priority. We cut the liver in half. One half goes to an adult, the other half goes to a child. You can see it's only 2% of our volume, but we do try to do these whenever we can. And living donors is a program that we're going to be starting this year. We've been approved to have a living donor program. And the idea here is to have a healthy person donate half their liver to you and have it scheduled. And we'll talk about that in a minute. When we talk about drug overdose deaths, as you can see, the maroon color is the rising number of drug overdose deaths. We are in the hotbed of the heroin epidemic, and so we have a lot of drug overdose donors as well due to the number of deaths that are present. And so we initiated a landmark program about 2.5 years ago using hepatitis C positive livers into negative patients. And we have the highest reported volume in the country. We reported our series of 35 patients that's going to be published soon. All received 12 weeks of treatment with a 100% cure rate. There were no side effects that were an issue, but the important finding that we had for the first time was that the equivalent survival to people that didn't get Hep C livers. So it's safe to use, we can treat your Hep C, and patients have done really well. And the idea here is to open up access for you with as many different kinds of organs as we can find. We are doing the same thing with hepatitis B transplants. The hepatitis B transplants don't have a cure like for 12 weeks of treatment like hepatitis C does, but conversely, it's one pill that you take every day for the rest of your life, really with minimal side effects. We have the highest volume of hepatitis C and hepatitis B livers to use in the country. And an example of the safety, this is the lead surgeon at NYU. He needed a heart, and he took a hepatitis C heart for himself. And he has been public about that, just to show you its safety. Here's a picture of a beautiful standard criteria liver, a perfect organ used for transplant. You can see the difference compared to the cirrhotic liver. The transplant itself, when the liver has your name on it, we call you in. We don't always have the time. Transplant takes anywhere from 4 to 8 hours long, and then after the transplant, you wake up in the ICU. About 10 to 15% of the time, we send you home without a new liver because the liver we went to go look at was no good. That happens, but it's the only way to make sure that we look at every possible organ. How about living donor liver transplant? What are the advantages? Well, number one, it's a shortened waiting time. We can plan the transplant. It's an optimal donor graft because we know everything about your donor is usually a loved one. There's a shortened ischemia time because we have to take the liver out of one room and just walk it over to the next room. It gives us an ability to optimize your health before the transplant. And allows us to time some of the therapies of the diseases that we're doing. And like I said, number one, really kind of plan this out and do it in the morning on a date that works for everyone. And here's a picture, a schematic of kind of what this liver looks like when it's in your body. Here's the whole organ of the liver in your body. There's your heart, there are your lungs. And this is what the whole liver looks like. And if we gave you a living donor liver, it would be just the right side. And then sometimes we could do just the left side, but that's how it would look. It would be half the liver, and here's how half the liver looks when we plugged in all our connections. So just give me an idea how it looks on the inside with a pictorial. Here's a picture of my team going out to look at a liver. You can see the perfect liver inside of the body. And what happens? Well, commonly what happens is we have to store the liver before we bring it back to Cincinnati. And we were recently involved in a large nationwide trial looking at what's the right way to store the liver. Is it to put it in the old-fashioned way, which is put the liver in ice and then put it into a cooler and then bring it over here, which works well, and that's how we do 99% of our transplants, except we don't really know what happens to the liver when it's in the ice. Sometimes it undergoes some changes. So we were involved in the study where instead of putting it in the cooler, we hook it up to special solutions and we pump the liver. And we pump it while it's coming here and while it's waiting to be put in to the new recipient. And as a disclaimer, I did the first one in the country last April. The pump has been great, and I think it's going to be something that we're going to be doing more and more in the United States. So something you should know about. How about the incision? This is what your incision is going to look like. Sometimes nothing over to the left and just kind of a hockey stick. A couple drains that come out before you go home. As I mentioned, it's the highest risk of death. With 3% is higher than any other operation that's done. And so you can imagine the complication rate's high. It's a high reoperation rate at 40% and a high readmission rate at 35%. So that's national, that's us, and we're working on bringing those numbers down. What are some of our post-op goals? Number one, we want to return to productive life after the transplant. Number two, if you work now, we want you to work later. Number three, if you're on disability for your liver, you'll no longer need that after your transplant. And number four, we have recently gone narcotic-free after the transplant. As long as you are not on narcotics anymore currently, then you will not go home on any narcotics. And that has worked really well. So let's say you got transplanted, now what? Well, we talked about the risk of dying from surgery, 3%. Survival at 1 year, roughly 92, 93%. Our average length of stay is 9 days. That means some people leave at 5 days, some people leave at 55 days. But the average is 9 days. Why do people stay longer? Well, that's because they've had complications. Number one complication people have is a problem with the plumbing. There's 4 connections we do, and one of them can get kinked, clogged, twisted, blocked, and we have to do another operation or a procedure to unblock it. Number 2, the liver and the kidney are very tightly regulated together, and so a lot of people develop kidney failure. About 20 to 25% of our patients end up on dialysis and need dialysis for short term. Only about 5% of people actually leave the hospital on dialysis, and only about 1 to 2% stay on dialysis. So it's self-limiting, but something you should know about. Respiratory failure can also be common, and about 10% of our patients get a tracheostomy, which heals as a small incision in the neck, but temporarily gets you off the ventilator. And a lot of times we want to do that to prevent pneumonia and things like that. And then the big one is you put the liver in and it doesn't work. This can happen for a variety of reasons, a lot of which we don't quite understand. It happens 1% of the time. If it doesn't work, you need an urgent retransplant or you die. And so that's why we enrolled in the pump trial, because we're trying to understand what happens to the liver and how it works, because we want to avoid this one first and foremost. Thank you very much, and it was a pleasure speaking to you.
Hi everyone, I'm Stephanie, one of the liver transplant social workers, here to talk to you today about some of our programmatic requirements as well as how to be successful moving through the transplant process. So one of the main things that we will ask you to develop today is a support plan. Strong social support is very important getting through this process as well as post-transplant. It is our program's requirement that you have a support person be with you 24/7 for 4 to 6 weeks after transplant. This person can be 1 person, it can be 3 people, it can be 10 people. We just ask that there is a robust group around you to provide that support. The support person's requirement will be to make sure that your medication is administered in a timely manner, help manage household chores, doing laundry, cooking meals. Patients will not be able to hold or pick up anything over half a gallon of milk for about 6 weeks after transplant, as well as provide transportation to all of the post-transplant clinic appointments. That is very important. Each transplant appointment, you will be required to have a transplant support person with you, so that you have an extra set of ears just to gather all that information and help you remember for later. The next part of this I will be talking about will be some resources that are available to you through our program. We have a transplant psychologist and a transplant psychiatrist on staff. If that's something that you're interested in, ask your social worker and we can facilitate scheduling an appointment with them for you. We also have peer supports. We have patients that have volunteered that are post-transplant to meet with, to call, to provide support to our patients that are going through the full evaluation stage. If that's something that you're interested in, that's something also your social workers can connect you with. We also have a transplant support group. This support group meets in person once a month. It's always the second Wednesday of every month from 6 o'clock to 7:30. And once a quarter, we hold it at the Westchester location. We also have a transplant Facebook page. If you are interested in more information on that transplant page, social workers can also give you that information as well. One of our programmatic requirements is that each patient has a living will and power of attorney on file. These documents vary by state, so depending on your state of residence, your social worker can supply you with the correct documents and we can help you through filling those out and then putting them on file with us. We are a great resource for any of those questions as well. If you have any additional questions, feel free to reach out to your social worker. We will follow you through the pre-stage as well as post-transplant phase as well. Thank you.